Okay, so, who is speaking now?
Dr. Jain from here.
Dr.
could-
Jain, Dr. Pinto, and
Okay.
Dr. Ravi Battina.
Okay, good evening, sir. This is a 75-year-old man, and he has presented with recent onset angina, and he is not a diabetic, he is a hypertensive, so you can actually see the pressure touching around 180, and he has his echocardiogram is normal, essentially normal. There are no wall motion abnormalities, and EF is about 65, and electrocardiogram did not show any significant changes. Now, can you see this angiogram on this? Can you see the angiogram?
Yeah.
Yeah. So here it shows decent left main plaque stretching from middle of left main to bifurcation, and then ostial circumflex lesion, and then extending into the LAD ostium. And can you show the next view? Yeah. Then you can see that the lesion is extending down into the LAD. In between there is an area which looks relatively normal, but only IVUS will tell us whether that's normal or not. There is a sizable diagonal coming, and then there is another shortish lesion. Next one. Yeah, this view doesn't give us any additional information. Next one. Yeah, this is a elevocranial view showing the bifurcation of LMCA into LAD and circ. You can see the circ ostial lesion, and this is what the left coronary is. Next view. Now the right also has got a tight lesion, and we actually fixed it right now. Next one, just show quickly from here. We pre-dilated it. Next one, and yeah, next. There's nothing much to talk about the right. Just keep showing the views. That's a everolimus eluting Relicis stent, 2.75 into 32. 32. Next one, we post-dilated it with a shorter NC balloon. Next one. Up to 18 atmospheres. Next one. Yeah, this is almost the final result. Next one. Okay, this is the final result. Okay, now I forgot to introduce our team. Dr. Vasu, my colleague, Kimi, our chief nurse, and then technician, he just disappeared somewhere. Nagaraj is here, Prabhakar is somewhere, and this is how it is. Now I would like to know the panel's opinion about how we should approach this case.
So what is the plan?
Well, I was thinking if you would suggest something.
No, we asked.
Hyperintense?
It looks like you have, disease as you've described in the distal left main, long disease in the LAD, and some osteal disease in the circumflex.
Yep.
It looks like a favorable, it's a long left main,
Yep.
but it looks like a very favorable angle for a T-type of strategy.
Could I request you to be a little louder?
So I wonder if wiring both, treating the long LAD lesion,
Okay.
and then having a tap technique with a blocking balloon
Okay.
for the circumflex would be one way to do it. There are
Okay.
obviously a number of bifurcation stent strategies that could be used.
Okay. You are suggesting put a single stent across the circ and then see how it goes. Is that what you are saying? Hello? Not able to hear. Hello? Okay, fluoro? I didn't tell you to do anything. Okay, switch off the fluoro. Hello?
Yeah, you're audible now.
Yep. So I wanted to ask you, you are saying that you put a single stent across from left main to LAD and then see how it goes. Are you trying to say that? Heparin you given?
Unfortunately, we can't
You-
hear you, but I think we can hear we can see what you're doing.
No, I was just asking you, just adjust this. Huh? No, he says he's not able to hear me. They are able to, we are able to hear them. Put it properly. Yeah, am I more audible now? Sir, give 1000 units heparin. Okay, now that we have discussed the case, we can go for doing the remaining case. You can go to Dr. Khanna and come back if that's the this time. Flora. Test was. No. Give me ordinary wire. Give me ordinary wire. Keep that. Be careful with this. Hello, you are able to hear me now?
We are able to hear you now.
Yeah. So I was wanting you to let me know what is your suggestion how to do this case. Ordinary wire.
Hello, Sarat.
Yeah.
What's
Yeah.
your plan?
Yeah, so I think if I'm audible, I would say, I thought I would wire this circ LED and the diagonal and go for an IVUS to see where exactly the plaque, what is the severity, circumflex ostium, so on. Well, most of the information we know. And then I would like to put a single stent from LM to LED and then give a pot in the LM. That's what my plan is, and if the circ develops any narrowing, I may put another stent in the circ. That's what the plan is. We are having a difficulty here with the guide catheter. We tried multiple guide catheters, but we are not able to get this. We could engage it with a diagnostic catheter with great ease. Give me the wire. But the guiding catheters, we have already tried multiple guides, and we are not able to engage it properly. Yeah, give me introducer. Give me introducer. Is this the N wire? Put it there. Yeah, you could do that. You could go to Dr. Khanna's lab and then come back to us. Yeah, Flora. We could,
Otherwise, Sarat will get upset.
you take one AL catheter, AL N catheter. Am I audible?
Yes.
Okay, I'm not hearing anything from you.
Uh,
Huh?
so what is the strategy you are doing? You are going to do a T-stent or a cullet or
No.
what's the plan? Or you want to just keep a single stent strategy?
I'm going to keep a provisional stenting for this circ. The circ is the main vessel. We will do a provisional stenting for that circ. Most likely it will be a T stenting. Give me a test. Most likely it will be a T stenting. Slowly, slowly. Yeah. Ask him to take a deep breath. Yeah. Test. No, you should be ready for this. Huh? Okay, I think we are having difficulty with this guide. We will take another guide. So, why don't I suggest you to go to Dr. Khanna's lab and come back to us? Test?
We'll go to Khanna's place at 6:25. So we have
Okay.
still
Okay,
we
okay.
have still 10 minutes time. So we'll
Okay.
be there with you 10 minutes.
Okay, all
So
right.
that we'll go there and come back to you. So
Yeah,
we're there with
yeah.
you live now for another 10 minutes.
All right, all right, all right. Test? No, this I think is unnecessary. Leave this.
You don't want to give surprise.
Be ready. No, just wait, just wait.
Why don't you change your guide to extra backup?
We have, okay, give me ordinary wire. Okay.
XB35 will be fine for this.
IV fluid is going, sister? Okay. The annoying guiding this we took. It was very good. This is too short and show me that. Show me the EBU which you have taken just now. ఇందులోనే ఇంకోటి చూడు. You bring this. No, just wait. You bring those these MAC ones. You bring them. Bring all of them here. Maybe a shorter one would do. This one was reaching here. Another. We have opened almost all possibilities. We checked. Any better idea? We can try this Sin Plus. If this is going nicely, why don't we do one thing? Go with a diagnostic. కాదు బ్రదర్, ఒక డయాగ్నోస్టిక్ తీసుకొని అదెంత అది 7 or 6? No, 6 we cannot do. అదే బడ్డే పట్టు అన్నీ తీసుకురండి. No, I was wondering if we put a diagnostic, put the wire, but you need a full length wire, extra length. Unde? Chiyan. Hey, Karuna. You be extra length. Once or twice we have done it like that. You can put on that. We can take a. A new 3.5. We have used this. We tried this. In the 7 French. This is. Okay, take the diagnostic. Bring it here. This is the same one we used? Come. Okay, fluoro. Fluoro. Okay, yeah, I know that. We are trying to, we have a very basic problem of a guiding catheter. That's why, we are struggling with the guide. That's the reason we are not able to talk much to you. To
So Sharat, what is that guiding now?
No, what I've actually, before we came live, we tried multiple guiding catheters. Surprisingly, it was, we have used an extra backup, we used a Judkins, we didn't use Amplage, all right. So, I used a total of 4 guides, of which 2 are EBUs and of different lengths, and so I just decided that I'm going to see how the diagnostic catheter, I will put a wire in this, an extra length wire, and on that I am going to exchange that with a guiding catheter.
Okay.
Yeah, rarely it is required, but now it looks like it is required. Yeah. Okay. So, okay, put a torquer to this. We actually wasted almost half an hour of heparin time on just engaging. Put it properly. Put that properly. Remove all those ECG wires. No, it's not VT. He just removed the leads. See, you can see here the heart is moving. Okay, give me this. Put it here.
Then on the, you want to exchange.
No, this is okay. Fluoro. Okay, put a little mag and test. Small test. Small test. Put the table properly and freeze the table. Alright, let it go into this. Test. Test.
Sharat, you said you already tried extra backup, correct?
Yeah, correct. Move this here, move it this side. Move the table this side. Yeah, correct.
So you used one Judkins and an extra backup, they're not hooking.
No, they are not sitting, and the patient also is not a particularly cooperative gentleman. He is making life difficult. He doesn't take breath as we tell him. Okay. Now what you do, you give me an ordinary wire by the side of it. No, put the patient properly. Okay, give me ordinary wire. Okay, fluoro. Okay, yeah. Now, unless we put an ordinary wire on this into the aortic root, we will be, leave this, give me that. The guiding catheter will not go. So, here we generally, this doesn't happen often. No, this also should be an extra support. If it is just average length, it will not be enough. Extra support wire you bring.
Extra length, full length.
Full length, yeah.
Full length
Yeah, they will bring. You can give me extra support, this one. Not Termo. No. Regular wire you can give, or you can give me a amplage. Yes, sir.
Sharat, we're going to Delhi, connect it to Khanna, and
Yeah.
we'll come back to you.
Yeah.
Keep all the steps. Yeah, you are now audible and seen also, Sharat.
Okay. Just 1 second now. Take a cine. 1 second. second, let me just put it back. That's why, you should give a small test and then give a test. Okay, I will come to you. As I told you, we engaged it with a diagnostic catheter. Go back few times.
Can you show all the steps to us?
Yes, yes. Scene minus, keep going minus. Otherwise, you go back into that view. It will take a long time. No, go into that multiple frames, multiple views one. Okay. Now, okay. Not no. Come down. Right. Show it. Now, we couldn't show you that re-engaging with the guiding catheter. What we basically did was that we engaged it with a diagnostic catheter, took a 260 centimeter whisper wire and got it into one of those branches, the small unimportant branch, and on that carefully we pulled out the diagnostic catheter and took a guide. This time it is a JL 3.5 guiding catheter. Just give him some fluid and take care of that pressure. And then we exchanged it. We finally sat there. Then we wired the circ, the major diagonal, and the LED, of course. Yes, and here you can see dilatation. Next slide. Next one. Yeah, we got the balloon down. And next. So there is a lot of discrepancy between the LMCA proximal LED to distal. So what I did was I took a 2.5 into 18 millimeter stent into give some fast IV fluid, and you can see here the stent is positioned after the major diagonal. Next one.
Can you tell which stent it is?
This is a pristine stent, which is a Relicis. No, it's okay. It is a Relicis company's stent, which is basically Hyderabad produced stent. I use it dime a dozen. It's a very good stent. It's a neurolimus eluting cobalt chromium stent. Okay, next one. I know this stent requires, just go back scene minus. This stent requires another touch up with a short 2.5 millimeter balloon. I have not yet done it because my first concern is to get a stent across the left vein into this. I can always do it at the end. And the patient started getting some chest pain. So I said I left that there. And now I have put another stent. This is a 3.5 into 28 stent, which is going from LM to this stent. Our wire into the circ is there, and we will see what happens after this. Okay, so scene plus.
So are you going to pull the diagonal wire so as
Yes.
to double jail it with this?
Yeah, this next one, this is a balloon. We are just measuring the length, and yeah, this is the stent which we have positioned. Next one. Okay, now scene minus. Vasu, give me a, okay, fluoro.
Dr. Sharat, Dr.
Yeah.
Pinto is asking you want to remove the diagonal and rewire it because you'll be double jailing it.
Yeah, you are correct. You are right. It's not exactly, yeah, it's, go to scene minus, 1 minute, remove the fluoro. Scene minus. No, this stent which we have put, in fact, this idea crossed my mind. We put it after the first diagonal.
Okay.
So at the most it will be jailed only once.
Yeah.
So you can see that here. It's the marker is at the level of the diagonal, but not the stent. Okay. Now fluoro. Okay. Take a test.
This is 3.5, 28?
Correct. You might have said we will put a little bigger one, 4, but this stent will stretch up to almost 4.2. So I'm not really tensed up about this. And this stent is just entered. Can we go to epicranial and see how much of this proximal stent is into the distal stent? Pinto means, is it Brian Pinto?
No, it's Dwayne Pinto, another Goan guy.
Okay. Now put a little more mag. Yeah, I think this is a little more than required. You can probably come out. Yeah, test please. Do a cine there. Yeah, that's okay. It's not much into that. Okay, Inflate it, fluoro. Quickly go up, yes, and 10 and deflate it now. Deflate, we will see. One should avoid putting a high pressure dilatation of the stent at this point because we still have to get into that circ. Okay, do it again now to 10 atmospheres. Yep. Yeah. And yeah, I think I'm happy with this. Deflate it now. I will do post dilatation after this. Yeah. The patient's pressures were originally 180 like that, and now they have come to about 130. 130? Huh? There are, of course, multiple wires and balloons, so the pressure may be actually little fallaciously low. Okay. Now let's remove this balloon.
This is also same stent, pristine?
Yes, this is also same stent.
Good.
I generally believe that if you use two stents side by side, both should be of the same make, because the said that, okay, 1 minute. If you use different make stents, it will be a predictor of stent thrombosis. Yep. Okay, by and large, I generally avoid putting two different make stents side by side. Okay, now let's take a test and see. Okay, pressure also looks good, 150. Okay, give a small test. Okay, yeah, good enough.
We are not able to see the pressure tracing here.
Yeah, pressure tracing is now 150. You know, this doesn't come on this particular monitor. Okay, do a cine. Now he's stable. Cine. Okay. Okay, he has put his hand there. Okay. So now if you see this, the diagonal is very much patent, and there is a bit of course, pinching of the diagonal, but I think I will attend on it later. I will first try to deal with the circ. Okay, can you come to the areocaudal view? Okay, fluoro. Okay, let's see this cine. A little more mag. Okay, cine. Okay, that shows a significant narrowing of the circumflex ostium. We knew it is likely to happen, and we need to do a kissing dilatation here and perhaps a stent also. Okay, so give me a torquer. Okay, this is the LED. Yes. Take out this. Yeah. Yep. I'm removing this diagonal wire because, can you go to scene minus? Yeah, this.
Sharat, you want to take another wire, enter diagonal, or you
go
want to remove this wire?
Okay,
and
fluoro.
Sharat.
See, you can see that the diagonal wire has come out pretty easily. Okay.
You know, I may have used the diagonal wire to recross into the circumflex. That way you know that it's not under
Are you with
stress.
us? I think they are not, no?
There is
Okay,
disturbance.
1 second. What we'll do, we'll check the ACT. Give me a routine, no. First give me an ordinary syringe. You are there?
Yeah, we're there. See,
Okay.
what he was suggesting is take this diagonal work in.
Diagonal? Say it again.
He was suggesting
Uh-huh.
take this diagonal.
Yeah.
He's suggesting take the diagonal wire into circ.
that's what I'm doing. I have already removed the diagonal wire, and this is the LED. Okay, fluoro. Yeah, that's what I'm doing. I removed the diagonal wire. It came out pretty easily. You were little off live for a moment, but otherwise, yeah. Okay. Well, putting the wire like this goes against the theory of pot, but here the reason I'm little concerned about it is that the circ is already severely pinched. So I'll try to get into this circ first and then only do anything else.
I don't think you have to worry about losing the circ with the pot.
Okay. May I know who is speaking now? Sorry, I
This is
didn't.
Dr. Pinto from Boston.
Okay. So you're not bothered about.
I'm not bothered by it. I would
yeah,
just do the
yeah,
pot and make
I
it
agree
easier
with
to
you.
cross.
Yeah, probably it doesn't make a difference, but let's, the main reason people are little concerned about it is that the wire may not again go through it. And here there is already a severe pinching of that. Let me just give a try and see. Yep. Okay.
Got it.
Okay, show me a little, go down.
What wire is it, Sharat?
These are all 3 BMWs. We used initially a whisper for a while, but now we have removed it because there are too many bifurcations, and if by chance you jail that, you will be in trouble. Okay, that's fine. Give a small test. No, and, yeah. Give a small test. Little more test. Yeah. That's fine. So we got the circ now. This is the circ wire. Okay. Yeah. Okay. Okay, come with this here. Yeah. Okay, so what you do, you give me a 4 balloon, 4 balloon, and we will pot this proximal, the LM part of it, and then we will see if required we will do a kissing balloon dilatation, probably. Huh? This is the? No. Okay. This is the original circuit. Fluoro. Okay, we can keep it there. We will see of doing this. Okay. Table. Okay. Okay. Give me a 4 Yeah. This is the LED. Huh? It's the LED. Okay. The new circuit, new wire. Huh? Okay. Okay, give me that. Yeah. Yeah,
like
this.
to do the FFR this moment prior to the balloon dilatation?
Unfortunately, I don't have the FFR system here right now. This is a big circ, and would you really depend on FFR in this case? I agree. There are many people who have shown that what looks like a severe lesion can be sometimes FFR negative.
I think from the very beginning, I would have said that that's a significant circumflex lesion and gone in with a 2-stent strategy.
Okay. We can still do that. We can put a stent there. You would, okay, put the table first properly. Yeah. Are you on the right side?
Because if we're going to do it based on angiographic appearance, it's never going to look perfect.
We have put it on the wrong wire. We want to put it on the LED wire, no? LED? Fluoro? Okay. Okay. Remove that too big mag. Okay. ACT 310. Okay, ACT is 310, so we have reasonable time on our side. Okay. Okay. Just give it back. Hold this. Okay. Put it on this. Yeah. Fluoro. Okay. Okay. Yeah. Go ahead. Fluoro. Okay. Okay. So, right. It has this. What is the length of this balloon? 12. Okay. Fluoro. Okay. Can you go a little RAO? Little RAO? Little. Bus. And now you do a cine, please. No injection. Okay, enough. Okay, do it. Go up. Yeah. Quick. Go to 12. Yeah, deflate now. Okay, table this side. Okay, take a cine there. Okay, so what's your opinion about this? We went up to 12 atmospheres, which comes to approximately, it's 3.95 millimeters. And the circ looks good. In fact, go to scene minus. Minus. Okay, you freeze this and put it here. Okay, now go to scene plus. Plus. Okay. Yeah, if anything, the circ looks better. The circ looks better. I think we can go for a higher pressure. Fluoro, please. Okay, go to 16. Quickly go to 16. Yep. Deflate it now.
What balloon is it?
This is a single balloon. Yeah, this is a NC Traveler. This is an Abbott, one of the later generation balloons. Okay. Right. All right. Now what we will do? We will see whether this will go in and then do a. Okay. What time you gave the second dose heparin? 6:45. Okay, half an hour back. Okay. I think we should be done. Okay, just prepare it ready and keep it. Huh? Okay. So yeah, let's take a cine now. Fluoro. Okay, test. Small test. Okay, so do a good cine here. Okay, so what is your opinion, Dr. Pinto?
I'm not happy with the circ.
Yeah, even I would feel that you should put a stent there. It has got a mild dissection there and considerable narrowing also. So what we will do, we will take a short stent, about 12 millimeters should be enough. The diameter can be 2.5, okay, 2.5, 12.
I'd take a bigger stent.
It's a bigger stent. Circumflex looks 3.5.
You want a
Yeah, I mean
big,
a
okay.
3.5.
Okay, this stent, okay, take a 3.0, 3.0.
And I'd leave a balloon in the LAD.
Yeah,
Then,
yeah, we need to park a balloon in the LED. Okay, so give me a, yeah, this stent you can open. Yeah. This is the LED.
You were 3.0 in the LAD, right?
Sorry.
How big was the stent in the LAD?
No, the stent into the LED which we put is a 3.5, which is extending from LM into LED.
So that stent looks much smaller than the
Yeah,
circumflex in the...
we need to dilate that proximal portion of the LED much more than this. Our
But
initial aim was,
I mean, as you're sizing the circumflex, even though that this is magnified,
just wait, we need to put a balloon there in the
the
LED.
circumflex will be
Give me a,
magnified somewhat. The mid-LAD is
fluoro,
smaller
please.
than the circumflex.
Table. How much contrast is used till now? Okay. Okay, this is the LED. So let's put a balloon in the LED. Huh? Give me a 3 millimeter balloon into LED. 3. You know, ask him to bring a 3.5. 3.5 balloon. All the branches are fine. Huh? 3.5 balloon into LED and then put this stent. If the stent doesn't go by any chance, you can always inflate and go. Okay. Fluoro? Okay. This is LED. Huh? Wire tip? Okay. Okay.
You know, one trick that I do when I'm working with multiple wires
Okay.
is
Okay.
I put a bend on the back end of the side branch wire.
Okay.
So that way I know which one is which, especially when
Ah.
I'm using the same wires. Then you have two
Yeah.
BMWs here. So I'll use with my finger, I'll just put a bend on the back so I know which one is which.
Okay. Okay, put this one, this is it? Okay. Okay. Okay, so we are putting a 3.5 into 12 balloon into LED.
Say a regular balloon or a non-compliant?
This is a non-compliant balloon. Okay. Okay, we park it there. We will see. Okay, now take the stent.
You want to open the struts or directly take the stent of the circumflex? This mouth of circumflex. You want to open the struts with a smaller balloon or you directly want to
Go
go
to scene minus. Go to scene minus. Yeah, that's one second. Scene minus. I think this should go. No, the mouth of the circumflex itself seems to be pretty good. This is a
It's
3
not going to
into,
go through the stent struts though in the LAD.
sorry.
It's not going to go through the stent struts in the LAD very easily.
Let's see this. Give me. This is a 13 mm stent. Huh? No, you are at a. Fluoro. Well, put this, remove that super mag. Give me a torquer on this. Fluoro, please. Yeah, put it properly. Let's take this wire a little more. Yeah, give me a little test. Okay, test.
Guide బట్టి వస్తుంది.
No, it's okay, it's okay. Okay, keep it like that.
గైడ్ సపోర్ట్ లేదు, స్టెంట్లో వెళ్ళాలంటే ఏంటి?
Okay, fluoro. Well, if it doesn't go, I'll anchor it with this LED balloon, but it looks like it is moving slowly and slowly. Maybe a little more patience it should go. Pressure. Okay, give a little taste.
వెళ్ళా.
Mm-hmm. Okay. Okay, patient is nicely sleeping due to sedation. Okay, do a little mag. Yeah. Remove that mag, please. This is the stent. This is the stent. Fluoro. Yeah. This is the stent. Huh? No. Okay. Okay. Fluoro.
The circ wire is coming out.
Yeah. Yeah. I think better to anchor this. Okay. Give me a little test. Okay. Okay, taste. Okay, give me an indiflator for the LED. Move the table a little up and test.
So what are the plans, Sharat, now?
Yeah, I'm just, I'm going to inflate this LED balloon and then try this it's almost gone. It just needs a little more push. I think since the last part is not moving easily,
So you're anchoring it, correct?
I will anchor that. Okay, do a little mag. This is the stand. Okay, yeah. Give me the indiflator. Yeah, inflate. Okay, inflate this at a relatively low pressure. Yeah. And now deflate it now. We will go a little down because this balloon is inflating close to the circus. Yeah, inflate it now. Go to about 6 or so. Okay. Yeah. No, that's because of too many. Okay. Yeah. The anchoring seems to work. Okay. Deflate that balloon. Okay. Yeah. Now get the indiflator for this.
Much better.
Yeah. No, that's because of too many balloons and all. This will be 150. Don't worry about the pressure. Yeah. Okay. So, what is your suggestion? Which is the best view for this? Do a mag. Okay. You take this. This is the stage? Yep.
I think you can come LAO caudal. A lot of
No,
caudal and a lot of-
unfortunately, what happened is the LAO caudal, it's just not showing the ostium of the circ. This is the best view, in fact, whatever we could see. Okay, give a small taste. Yeah. Now, let's take our time and then decide about this, because you can see the marker is at the ostium, but not the stent. Yeah. Yeah. Is there further magnification? This is all. Any mag? Last. Okay, taste. Okay. No, that's little too much. Okay, do a cine there now. Okay.
Looks good.
Is everybody happy there?
Yes,
Yeah,
very good.
it looks good.
Yeah, the marker of the beginning of the stent, if you see, it is just about projecting into the LM, and I can later pull back this balloon. Maybe I can pull it now itself, the LED balloon, fluoro. Okay, that's good. Okay, go for a cine again. Okay, do this stenting. Do the stent, fluoro. Yep. Yeah. 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 Okay, madam, you go up. Quick. Yep. Cine, please. Cine, quick. Deflate both.
Sharat, you have another 5 minutes.
Yeah, I think we are almost done. If we have this, all that we are left with is to do a dilatation of.
I think the step here he did simultaneously circ
Yeah.
deployed and LED. I think they
I
should
prefer
deploy
to
and
do it
then
as a tap.
yeah.
So this
No,
was
you know,
a modified T-stent approach. I might have deployed the circumflex
stent?
stent, pulled a stent delivery balloon out, inflated the LAD balloon to crush the portion sticking out into the main, and then done kissing balloon inflation.
One could argue on this kind of situation. Sometimes what happens is yep, okay. Now what is the pressure? Pressure is good. Okay. Now what we do, you can both inflate, okay? But 1 second, let me just see how it is actually. Cine? I think that's excellent. Huh? Yeah. No. We have to do touch-up dilatation of this. We have a lot more work on this case. Don't Don't, okay. Now what we do, the circumflex stent, you have to go, what pressure you went earlier? This is the stent. You go to 14, and madam will also go to, okay, ek minute, was deflate, okay, that's fine, I think that's okay. Yeah, okay, go, both of you go up. Yeah. Yeah, both of you go, 14, 14, 14, 14, 14, 14. Cine, please. Deflate. Yeah, we are done. We have got a very good result. We used. Okay, Fleur.
So what's the joke, Sharat? We'll also laugh at it.
No. Well, some of them are kind of, what we are basically saying is that we got a, looks like actually angiographically very good result.
No, it's excellent
No,
demonstration.
you have
Superb.
not seen, have you seen it?
Yeah, we saw the angio.
Okay, yeah, let's do, this is the high pressure dilatation. After, we gave a high pressure dilatation.
Sharat, you have not given in the proximal LAD 3.5 high pressure
Yeah.
dilatation. That
No, I'm going to attend an LAD now.
Yeah,
My main concern was the circ, and I wanted to do it while I'm still on live. That's the issue. So, now that that's done, I'm a happy man.
Yeah, it's excellent.
I just see this last shot, and then we
Sure.
can go off
We're all
live.
waiting for the last shot.
Yeah. Okay, Floro. Okay, Cine, please.
Yeah, excellent result.
Okay, thank you. I think what we'll do with the rest we can do off live.
Yeah. Yeah.
And
It's a nice
thank you.
case,
Thank
nice
you very
demonstration,
much.
excellent case.
Difficult case.
Thank you.
Difficult case. You did nicely demonstrated the tap technique.
Yeah.
It's nice
Thank you
case.
so much. Thank you so
Welcome,
much.
welcome.
Bye-bye.
Thank you.
Claro?